Again, Colonel Rasmussen, again, as you heard from one of our JPC groups there, and Combat Casualty Care, and then Kirby Gross, who's sitting down there at the Center of Excellence for Trauma and Joint Trauma, what I call advancement. And so, kind of, to Mabry's question, and that's what in fact, I'm even learning stuff as I listen to all our folks talk. It's about getting the product to market. And we talked about this, and we've got a lot of folks doing stuff out there, but how do you get the product to market? How do you get it to the right customer, whether it's education and training, okay, or whether it's to the clinician, and our system, because it was fragmented, there wasn't an easy way to get the product to market, and that's why I think the Defense Health Agency is going to be that conduit, that highway to get the product, the process, the algorithm, the process improvement, or just a good old-fashioned gadget to market, either through education and training, or through the clinical ops group, or through HIT. So I'm actually pretty excited, and you already start hearing these guys all day long and all day yesterday referencing how I'm counting on Miller. Miller's got more to-dos than I've seen of anybody here these last 2 days. You got that? Yes, that's what I'm talking about. So, but good. But here's the guys. Rubber meets the road. Why don't you guys go talk about it?
Thanks, sir. Kirby Gross, Director, Joint Trauma System. I have nothing to disclose. This afternoon, Colonel Rasmussen and I will discuss the Joint Trauma System Defense Center of Excellence as a strategic model for strategic partnerships. In the past 157 months, there have been more than 5,800 deaths, more than 52,000 wounded, and 6,800 deaths. This has been a long war. However, the MHS deployed trauma system has never responded better. How have we responded? Colonel Basil Pruitt and Colonel Rasmussen described in article J Trauma, Journal of Trauma, 2014, their perspectives. Colonel Pruitt, as you may recall, was a surgeon in the Vietnam era. And there are specific things which these authors identified which they feel have impacted the improvement in outcomes. We are in the era of lessons learned. For example, this recent journal here is devoted to lessons learned from the past conflict. And so we in the military health systems are in the season of lessons learned as we wind down in theater. The first lesson learned that Dr. Pruitt and Dr. Rasmussen identified was that the joint trauma system provides clinical guidance. And this clinical guidance is obtained by vetting and integrating solutions from researchers and performance improvement. The joint trauma system also serves as a sensing tool. Being deployed, the joint trauma system leadership is able to identify those current issues which warrant investigation, which warrant research, and provide gap-driven research and development programs. And the third lesson learned is the need to develop a military medical academy, and one which has actually been proven to be effective. The AMSUS has served as the real baseline for an academic foundation for career medical leadership. So these are things which were not available back in Dr. Pruitt's era in Vietnam. And the case fatality rate has demonstrated improvement since then. But now we have direction. And the Joint Trauma System, as a Defense Center of Excellence, role is to help provide that direction. The mission of the Joint Trauma System is to ensure all combat casualties have the best opportunity for survivorship and to minimize morbidity. Many of you have heard the saying, right patient, the right place, the right treatment at the right time. And that very much summarizes the way the JTS and JTTS, our downrange colleagues, have impacted outcomes. The Joint Trauma System was identified as a Defense Center of Excellence in June 2013. So how does the Joint Trauma System actually facilitate the improvements? One is performance improvement. And the performance improvement projects of the Joint Trauma System and Joint Theater Trauma System are based on data. The performance improvement projects are directed and guided by data obtained from the Department of Defense Trauma Registry. Another way in which the Joint Trauma System impacts the improvements in care is theater leadership. Until very, very recently, the Joint Trauma System, Joint Theater Trauma System, has had a senior trauma surgeon in theater continually, and particularly from the Joint Trauma System since 2011. And of course, there is a Joint Theater Trauma System director dating back to 2005. The Joint Theater Trauma System director provides senior leader oversight and interacts with surgeon colleagues. And one of the opportunities we have to impact outcomes is by that direct collegial interaction with our trauma surgeon colleagues. One of the benefits that we have is that we're not in the chain of command of our clinical colleagues, and we receive much information, and it's a way in which that sensing is indeed facilitated. Today we conducted our weekly Thursday Casualty Care Conference, and we had, I estimate, approximately 250 participants on the phone call even today. The Department of Defense Trauma Registry, this is what our processes revolve about. We have more than 50,000 combat injured, and we have data on the vast majority of those injured. And then the clinical practice guidelines. Using the clinical practice guidelines, which are data-driven, based upon information obtained from outcomes as directed by the clinical practice guidelines, we're then able to develop even further best practices. As care is provided, care is recorded in the medical record, that information is then entered into the registry, the data is then analyzed, best practice, care is provided, and the cycle circles again. The faster we can get that cycle to spin, the better opportunities to improve care. Of course, the Joint Theater Trauma System developed back in the 2004-2005 era and was guided and directed by trauma surgeons. Over the past several years, we've recognized the true importance of the point of injury. So initially, if you look at the triangle, we were focused on that center third. Then we recognized the importance of the rehab, and now if you look at the lower portion of that triangle, we've started to recognize the true importance of the point of injury. This is where we recognize the best opportunity to improve outcomes, as was mentioned earlier today. However, we also have to recognize that we're working the continuum. So not only is it the specific levels of care, it's those pieces that keep the various echelons together through en route care. So this is the gamut of the joint trauma system. It's from point of injury all the way to rehab. And of course, there are many strategic relationships which are necessary. I'll let Colonel Rasmussen pick it up here. Over.
Thanks, Kirby. So thank you, Kirby. The strategic relationships we'll get to here. Kirby spent most of this time introducing you to the JTS and what it is. And I'm going to spend the next 5 or 10 minutes talking about its main strategic relationship, or for us and Rear Admiral Dahl, is with research. So it interfaces very importantly with the RDA and specifically with the Combat Casualty Care Research Program, elements of military operational medicine, and JPC-8 or rehabilitative medicine. So importantly, on one side in this model of the JTS and research, the JTS makes observations. It identifies gaps. Where does it do that? Well, on the phone this morning and really every week, in a sense, continuously for almost 10 years, the JTS has been listening to gaps. Those gaps are apparent in describing care of combat injured, right? So they identify gaps. They feed those into a requirements-driven research program that Admiral Dahl mentioned. So it's requirements-driven combat casualty care research. And then the research program endeavors to provide either knowledge solutions or material solutions. Some of the material solutions take 10 years. We've had instances where knowledge solutions from research have had a much shorter flash to bang observations, and it's not a material solution, a product, it's a knowledge product. And so that's how the JTS on one side feeds this into the research program. But then importantly, the outcome of that research, the JTS, it vets that output. So the JTS serves to vet, implement the results of the research, either knowledge products or material solutions, into its cycle of performance improvement. So it takes the products of the research program and puts it into practice. And as Kirby said, some of that is in the form of clinical practice guidelines. Evidence-based clinical practice guidelines aren't evidence-based unless they're supported by evidence, and that evidence largely comes from the research program. So that's a strategic, the research program is a strategic partner with the JTS. In the process, again, as I said, the JTS, they leverage other strategic partnerships, including these. These are just some that are listed here. The user communities are very important, of course, and for our research program, JTS is an important user community, but so are the COCOMs, international allies, military training organizations, senior military leadership. That's a very important aspect. Combat developers are a very important relationship for us. Requirements-driven research program we've talked about. Uniformed Services University. This is the first war that a sustained period of combat where this nation has had the benefit of a Uniformed Services University. If you think about it, the long, prolonged period in Vietnam, we didn't have that. For those of you who don't know, the Uniformed Services University graduates 175 joint from the beginning military medics every year. That institution started in roughly 1973 with its first class, so at the end of Vietnam. So AMSUS is a very important and now maturing strategic partner. And then certainly civilian and academic institutions, universities, and then industry and national trauma organizations. Sort of looks like this schematically, at least to me. We've talked about the JTS being the bookends, the DCOEs, the Defense Centers of Excellence, being the bookends. On the left side, again, they feed into this research program, and in the middle here is the military trauma research programs. These are the entities that perform the research. Here's the Defense Health Program, or DHP, the Army's labs, the Navy's labs, the Air Force's labs, and then the knowledge that comes out of the material solutions. Really, the JTS is the left-sided bookend. It takes that product of research and implements it into practice. And on the top are the user communities that I have described. And then I think the AMSUS, I view it as the foundation of this. It's really it underwrites this effort. It underwrites the effort by providing, again, 175 graduates a year, joint from the beginning. It's our academic foundation of this research and this cycle. Those graduates have long commitments, and really they are our future military leaders. Not exclusively, it's not the only way we get leaders, but it is a very important underwriter of this process.
So can you go back one?
Yes, sir.
So where does the JPC, Combat Casualty Care, fit in that construct? In other words,
Sure.
you know, in the general sense, there's somewhat of the prioritizer or the what I would call the gatekeeper that feeds the books on the bookshelf.
Yes, sir. So the research
Joint requirements.
The
not-
joint,
yeah.
yes, sir. It's in the middle. So the research JPC 6, all of the JPCs sit in the middle, and we sit with our I guess our right ear to the phone. This morning we decided we dial in and we listen to these things. We have our right ear is with the combat developers, the requirements developers. So we're in the middle, and then we develop the knowledge and the material solutions, and then those come out the left side. And they go back into these user communities, whether it's the AMED school, whether it's identifying, as Colonel Maybury said, you know, this isn't a material solution, it's not a knowledge product. Actually, this is training. There's a training element to this. And our research identifies that, and that goes out the left side. So, sir, the JPCs rest in the middle. If that answers your question.
Good.
Okay, yes, sir. This is it's interesting. The nation has actually come around to recognize that this This is an Institute of Medicine report that it describes. It was entitled Best Care at a Lower Cost. And in this system, interestingly, or in this article that was sponsored by the IOM, they describe a continuously learning health system. And in this article, they talk about, for best care, Americans would be better served by a more nimble healthcare system that is consistently reliable, constantly and systematically and seamlessly improving. And they describe in this really the JTS. They describe, they're talking about civilian healthcare. But the nation has really come to recognize this relationship between the performance improvement and the JTS linking with the research programs as being a continuously learning health system. And I think it's an important, I put this up here, we've looked at this article, and it's actually sort of interesting and now being recognized nationally as a continuously learning system. So it's your continuously learning health system in trauma. The effectiveness of this model is shown here. Many of you have seen this. For those of you who have not, the dark line is the case fatality rate, which between 2005 and 2013 is decreased by an unprecedented 50% in Afghanistan. One may say, well, that is maybe due to force health protection, maybe it's due to the kinetic operational environment, differences in that, and maybe, but importantly, the gray line that's at the top is the injury severity score. So speaking for the effectiveness of combat casualty care and this model of the continuously learning system in trauma care that the military has developed or has evolved, is the reduction in case fatality rate occurred at the same time that the injury severity score was increasing. So that's a very, very important graph to consider, and I think it emphasizes that this model is effective for national security. This is a depiction of gap closure or resolving gaps. So this was an aspect of a report to the Senate Armed Services Committee staff following up on the GDF gaps. And what is shown here is on the far left, in 2008, these gaps were viewed as about 9% resolved. Whereas in 2014, after 4 to 5 years of this model of JTS and the Combat Casualty Care Research Program, these gaps are moving to be resolved. These are the priority 1 gaps that were defined in the Gates 2008 GDF. This was presented to Senate Armed Services Committee staff in earlier this calendar year. What we emphasize is that clearly the job's far from complete. These are priority 1 gaps, and one says, well, we are moving these gaps, but the priority 1 gaps are still less than 50% resolved. And so, again, evidence that this model is working to accomplish its mission of reducing morbidity, mortality in combat. There's also evidence that it's effective for Homeland Security. So this is an article or report that described the implications of this model for civilian mass casualty events. So the public has picked up, as was said a couple of times earlier, not just tourniquets and resuscitative fluids, but other operative strategies and route care strategies. And really, this is the 2-for-1 that the American public, I don't think, recognizes they get from this investment, meaning that they get improved case fatality rate in the U.S. service personnel, but they also get Homeland Security by taking these lessons into trauma systems and medical centers in the U.S. This was reported, many of you have seen some of these articles that followed the Boston bombings. These were some examples of articles of how this system and its products, knowledge products, material solutions, and even some training aspects are translated into the civilian setting. So the opportunity here is, I'm going to say opportunity and then the risk is going to follow, but the opportunity is sustaining and maturing this bookend concept of the JTS DCOE. It stands to further reduce these gaps. There's evidence that they are being reduced with further translation to the civilian setting. It solidifies this enduring legacy. The bookend model of the JTS, I think, can be applied, elements can be applied to other COEs. So there are other centers of excellence out there that we are working with to sort of talk about why and how this model works with the COEs feeding into the research program and then taking the output from research into their, so not everything applies to the other COEs. The JTS and the Combat Casualty Care has evolved this quickly by necessity. I mean, most of you in the room were part of building this plane while we were flying it in Afghanistan and Iraq, and that's why the JTS, this model's evolved so quickly. Some of the lessons, I think, apply to some of the newer COEs that are wrestling with their relationship to the research programs. The risk is listed here. It's been discussed. Resource constraints, indiscriminate funding reductions, and a drawdown of troop formations threaten to diminish the model and its strategic partnerships. And I think another very important thing I want to spend 2 or 3 slides on is that no other federal or civilian entities support the military trauma system model. So if the DoD doesn't do this model in trauma care, trauma research, it's not something that's picked up by the civilian setting, by the U.S. public. So no other federal or civilian entities support the military trauma system model or fund weighty amounts of military-focused trauma research. Where does research funding come from that's dedicated and programmed to address the needs of the uniformed personnel? Where does it come from for combat? It's the DoD. This is we're working with Jeremy Brown. One of our strategic partners is the NIH. So that if there's redundancy, it's managed redundancy. There's opportunities for synergy. Jeremy Brown's the director of the Office of Emergency Care Research. So this is, the DoD has 20 institutes dedicated to the spectrum of disease in the U.S. They don't have any that are dedicated to trauma. They have an office, which for those of you, there's no institute. Jeremy Brown has an office, which means it comes with no funding. But Jeremy has done this look at the DoD's and the NIH's research in trauma, roughly $300 million a year, depends upon the year and how one splices it with or without CSIs, but roughly $300 million a year for trauma research by the DoD. And the NIH's $30 billion budget a year, $34 billion in FY12, they really don't have any for funding. They don't fund trauma research. They fund, through Jeremy's, our collaboration with the NIH, we've identified $5 million in acute trauma research that the NIH does. But the point is that who funds this research, it's really for trauma care, it's really the DoD. So in other words, while there is redundancy in the federal government for research related to non-trauma conditions, there's infectious disease, elements of aging, cardiovascular disease. There is redundancy in that research in the federal system. There is no overlap. There's no safety net for military relevant combat casualty care research. Again, if the DoD drops the ball on the JTS and its integration with trauma research, there's no net to catch this. There's no National Trauma Institute that's funded to the tune of billions a year that's going to do this if we really nadir. So the risk is, reversal of these gaps. I mean, this is the diversion of focus and investment, re-exposes the deficiencies and the gaps. It could. Of course, it's the military's imperative of trauma systems and combat casualty care. So a backslide would be the risk. The risk would be case fatality rates that were, when we started the war in Afghanistan, were roughly 25%, hadn't changed much really since Vietnam. And so this is the risk of disassembling or not empowering this model. This talks about strategy. I appreciated this. This is from the chairman's second term strategic direction to the joint force. This is a quote by Todd Harrison. Some of you may recognize this individual's writing. He says, without resource constraints, strategy would be unnecessary. Limited resources thus create the need for strategy. So strategy is important. As resources become constrained, strategy and strategic thinking becomes more important. And I think that really applies to the JTS and the Combat Casualty Care Research Program as we go forward. And, I'll stop with that and offer to take any questions. Thank you.
Well, you got any questions? Always, back row.
What impact would you see the drawdown in Afghanistan having on your work? In other words, don't you kind of, if you're doing trauma research, don't you kind of need a kinetic encounter going on to generate your data?
It's a great question. So it emphasizes the need for strategic partnerships with civilian universities. The NIH is going to be very important. The gaps that we have in combat casualty care I think are still known, whether it's hemorrhage control, TBI, recovery of the injured. And so the gaps, I think, will be still present, but our ability to do translational research is going to be more linked to multi-center civilian trials. And that's a strategic partnership that I think we have but are evolving. And then I think also a strategic partnership with the NIH in being smart with the National Institutes of Health, not adversarial, but smart and looking at how we can leverage their programs. Kirby, did you have anything?
Yeah, great question. One, if we look at the results that we've described out of our performance improvement projects in the joint trauma system, we've looked at a very simple metric, alive or dead. And we need to begin looking at morbidity. Now, in the Department of Defense Trauma Registry, we have many data points, and now the personnel at the joint trauma system are no longer entering data. We need to build out our analyst section so we can then start getting better granularity and find out what sort of things have been done which have then been able to give us a better idea about morbidity. One of the challenges we also have, though, is we need to have a registry. We need to be able to link to other data sources. For example, if we wish to track morbidity, it's imperative that we work with the VAs and find out what the long-term outcomes are. So we have plenty of work to do. There's plenty of data there. We need to be more sophisticated in our analysis. Thank you.
Now, I want y'all to talk a little bit about, if you think they're going to work on current data that's left over, that's the only thing to do, you're crazy. So talk about, you guys are talking about fishing in another pond. So talk about the prospective trauma consortium with the civilian sector that Brother Holcomb's working down there.
Well, I think so this goes to civilian partnership.
Yeah.
So, not all civilian trauma mirrors in fact, not only a small portion mirrors the physiology of combat injury, but it's not zero. If a trauma center has 1,000, 2,000 admissions a year, there is a percent, even if it's 5 or 10% of those admissions into the civilian trauma center, shock trauma, for example, are patients who are in hemorrhagic shock. They are having complex operational scenarios that moving them from the point of injury in the air through rotary wing platforms to civilian trauma centers. So there's a big portion of civilian trauma, that can be studied and learned from. The physiology is still physiology of resuscitation is still very similar. So the idea would be to have a consortia or a group of civilian trauma centers, and we work closely with the American College of Surgeons Committee on Trauma to identify those civilian centers who would have this sort of material for us to, if you will, invest in the research. And we have right now we have at least 6 civilian multi-center trials in trauma that we are investing in through our program. So they will look at blood resuscitation on helicopters in the civilian setting. They'll look at medications, devices, monitoring devices, and these are our products that are going to go out and be studied in the civilian trauma center. The state of Maryland's interesting. It has, a coordinated en route care system. Stacy Shackelford's here.
They call that a monopoly.
Yeah, well, and this is a great example of a uniform en route care platform in which these patients that are severely injured throughout the state of Maryland fly on similar platforms on which we can then study en route care strategies. And so that's going to be very important for us to study elements of the civilian trauma.
And what I think what's key there is, again, as this war is winding down, we're already, usually we go, when the war is over, we wait to go, oh my God, what do we do? Again, we just give you examples with Air Commodore Walker, how we already laid in place before, we'd even left the house, how we're going to continue what we want to do. And so this whole prospective multi-site consortium from all the trauma centers, to aggregate what I call it, to aggregate the 5%.
That's right.
You know,
Yes, sir.
5%, you know, one place, but 5% plus 5% plus 5% plus 5, get your ant a hell of a lot bigger so that you guys can start driving, you know, conclusions from that. So it's pretty exciting what these guys are doing is, again, they're still looking inside the theater, evidenced by today's Thursday call, okay, 250 participants, but at the same time, the next day, they're looking forward, again, to opportunities as that starts to slow down. Now, I want to talk a little bit about, someone brought up first off, it ain't gonna happen on my watch, or, you know, sliding back, so, but number two is, and I don't want you guys running back and saying, hey, we're gonna do this, but this is what we're thinking, okay? Because we get in a lot of trouble for this, when we put ideas out there and they go back and tell their services. But here's what's going on with the Centers of Excellence, okay? All right, so this is the model. All right, this is a model. So what we're working on right now with a task force, looking at the Centers of Excellence, okay, what is the best way to position those Centers of Excellence to best get their product to market, to best hold them accountable, okay, for the money we give them, what they say they're going to do, and what's the product coming out, okay? So you've got all these, we've got 7 now, Centers of Excellence, designated, okay, designated MHS Centers of Excellence. So they met criteria, okay, they took a test, all right, and they passed, and so they are designated Centers of Excellence. Military Health System Centers of Excellence. Now, currently they're hosted, benevolently hosted, graciously hosted, sponsored by usually one of the 3 services, okay? Because we had no joint entity to hang these military health system, joint, technically, products, okay, these entities on. So you can see the discussion is being proposed, okay, that these Centers of Excellence it might make sense that they be aggregated under an overarching entity, most likely in the Defense Health Agency, most likely, okay, in the RDA realm, okay? So when you think about it, it's the Defense Center of Excellence, DECO, for psychological health and traumatic brain injury. It's Defense Center of Excellence for joint trauma, okay? It's Defense Center of Excellence for vision, hearing, cancer, and whatever the other 2 are, okay? So, but like he said, this model ought to be applied, again, for accountability, responsibility, and product to the other Defense Centers of Excellence, if it makes sense. And so what you should have now is, again, proposed, looking at, maybe, okay, is that you have a center, an overarching in other words, entity called the Center for Defense Excellence that has these 7 portfolios, okay? They don't own them, they don't manage them, but they hold them accountable like bookends to the bookends for, hey, you said you're going to do this, the money flowed, what'd you do with it, what do you got to show for me, and then help accelerate the product to market, okay? Because that's what happens, a lot of stuff, they censor, now what do I do? Who do I throw it over to? Because if you're hanging on the Air Force, or you're hanging on the Army, or you're hanging on the Navy, somebody will say, well, that's a Navy thing, that's an Army thing. They used to say that about the Joint Trauma thing. Oh, that's a CENTCOM thing. They say, no, it's not. Now that there's Center of Excellence, and it's MHS thing. So you can see where we're going, again, for these enterprise solution sets, again, based on, again, these guys, again, vision and strategic, thought process that we can now apply across the enterprise. So, again, I want to thank these guys, again, because it's incredible what they've shown you can do, again, if you put a bunch of smart guys in a room and give them a beer. So, yeah. Well, actually, you guys, yeah.